So sometimes one haptic tucks itself, which is nice. And then now it's time for the longer part of the case, which is actually the OVD removal. We like to let a little bit out through the main first, just to get the process started. And a lot of the work really is through the main. So you can see here, the actual ICL insertion was a lot quicker than the OVD removal. So our technique is to use BSS to kind of clump the OVD together and applying intermittent downward pressure on the main incision to let it burp out. You watch the iris throughout this part. I'm always very careful not to overpressurize the eye and then let all that pressure out through the main. So keep the eye kind of soft through the whole OVD removal process. We also don't like to use the IA, which some places do. That may create a risk of hydrating the crystalline lens, and we also just feel that it's wasteful. We very rarely have even post-op day 0 IOP spikes using these methods, so certainly using just BSS and a cannula seems to be extremely effective. Other ways to ensure as much of the OVD is evacuated as possible, you can see this rocking motion of the lens. This is manual expression allows the OVD to come from around the back of the lens. Sometimes you can rotate the lens around, just create spaces and pressure gradients to allow the OVD to come around. You'll also notice a decent amount of OVD does come out through the central port. It's important though that we don't aim for those ports ever during hydration because we don't want to be pushing all that fluid under pressure right into the crystalline lens. We're never aiming for those ports, but we do, you'll notice during the pressure gradients that OVD will come out through the ports. So here we are continuing, and especially with cameras like the Ingenuity, it's very easy to see the remaining OVD. There seems to be a little bit near the endothelium, and that bubble helps us to tell us that there's some trapped near the endothelium. So again, I'm very diligent about not having any pressure problems after surgery. So I might take more time than others just to really ensure that as much OVD is out as possible. After going through the main a little bit, we can switch to the para just to get fresh angles, really allow those vortexes to swirl around the angles. Again, that helps clump the OVD, and then gentle downward pulsing pressure on the main or the para allows the OVD to exit. Here's more rocking, gentle rocking back and forth, doing what we can to get all the OVD out that we can. And again, it might not all come out. There might be still some behind the lens, but that's okay. It will dissolve over time. As long as we get most of it out, we can feel good that there won't be any pressure problems after surgery. Now we vent a little bit more of the BSS out through the para because we want to leave the eye very soft after surgery. And then that's it. We've treated 16 diopters in under 6 minutes.
So as you can see, it's a very straightforward surgery, and I'm happy to answer any other surgical questions. I do have another video that I made for the American Society of Cataract and Refractive Surgery where we talk about other scenarios. But something that we've been working on is through the World College of Refractive Surgery is a curriculum. It's going to be called Refractive Foundations, and we've started an ICL, and we hope to delve forward to all the other specialties. And we've published also a book with the World College of Refractive Surgery that gives you a little bit of an introduction about LASIK, PRK, ICL, SMILE, and other procedures. The actual curriculum for ICL is on this website, so refractivefoundations.com/ICL. It's free, it's available for everyone. And we talk through, I know EVO ICL is a very straightforward and simple procedure, but we actually walk through a lot of different scenarios and helpful questions and questions that we get from a lot of audience when we're training surgeons. So hope this helps you all regarding ICL surgical. You're going to be in a situation sometimes where the ICL unfolds in a very weird way. And this is one of the common questions that I get is, what if, how do I prevent from getting a lens that's flipped? And this is actually what happens inside the eye. You can see sometimes it has to do with how the lens is loaded, but sometimes the foot plates will be tucked in a specific way. And it's very important to maintain the traction on there and rotate the cartridge appropriately, as you can see here, because as soon as you have the distal foot plates both emanating and they're open correctly, it's good. But if you have a situation like this where you just keep pushing, you're going to end up with a flipped ICL which you can see by looking at the haptic here. It's going to be the foot plate with the actual fenestration is going to be located towards the left side, which tells you that you have a flipped ICL in this situation. Now, post-op and recovery, the way I talk to my patients is I explain it, it's really a LASIK-like experience. And we try to make it that way as much as possible because patients are using the same medications as they would for LASIK. So I usually use an antibiotic and steroid 4 times a day for a week. They're wearing an eye shield when they're sleeping for a week, and really routine post-op precautions. And I follow them a day later, a week later, and a month later. So when we talk to patients, it's very much like LASIK, and you're going to have very much LASIK experience. It's only 5 to 10 minutes per eye, and make it a very easy experience for your patients. Now, post-operatively, there are a couple of things that you need to keep in mind. You have to measure the vault, and this is, again, a safety parameter. It's not as crucial of an issue compared to the previous models, but still, you should always measure your vault. And the way you measure a vault is you create a parallelopiped wedge with your slit lamp. You orient it 45 degrees, and you can see here you're actually splitting. You're measuring between the anterior lens capsule and the posterior surface of the ICL. This is the vault, and you're comparing it to the corneal thickness in the center. So is it 50%? Is it 100%? Is it 150%? And ideally, a reasonable vault is between 0.5 to 1.5 times the central corneal thickness. But with the EVO ICL, if a patient isn't having symptoms, I do not rush to go in and exchange. So if I'm seeing a vault, and the way we do it here is we measure with an anterior segment OCT, so I have an exact vault. So if the vault is less than 250 microns, I'm not rushing to go and exchange it. I usually monitor the patient because I have evidence that I'm not worried that they're going to get a cataract, and there's evidence to prove that. If they're above the vault, so if you're seeing a vault that's above 1,000 microns, I also don't rush to exchange unless the patient has symptoms, unless the angle is crowded. So if it's less than 10, 15 degrees, then I'll probably exchange and go down a size if that happens. But I wanted to go through a couple of example cases because sometimes going through cases will be helpful when we're making the clinical decisions. So this is the first case, a 26-year-old female. She wears contacts, and she has a history of a scratch to the left eye. She's currently in the army, so very active. And this is her refraction. So she's -3, a little bit of astigmatism in both eyes. So you can see very small magnitude of refractive error. Historically, anyone seeing this would say, I would never do ICL. But let's challenge that a little bit, because when you look at her topography here, and you look at the holiday report here, the right eye is decent. PACI is 560. Everything looks good. I would do LASIK. That's no problem. But you look at the left eye, and it's as if someone just like filleted her eye and scratched a good portion, because she's missing about 100 microns in the left eye. So she has corneal thinning, a very thin cornea in the left eye, and would not be a good candidate, in my opinion, for laser vision correction due to risk of ectasia. And so for this patient, you're looking at the true ACD, and true ACD is not the external ACD. So you can see here, when you look at ACD, this says external. This measures from the anterior cornea to the anterior lens capsule. So it includes the corneal thickness. This is not what you want to measure. You want to measure the true ACD, the internal ACD. So you have to subtract that from the actual pachymetry, or the central thickness. So it's actually 3.4, not 3.9. Because true ACD, or sometimes called aqueous depth, is the distance between the posterior cornea, the endothelium, to the anterior lens capsule, and that's the safety parameter, which we'll talk about ACD here in a little bit. But you can see here the Bellin ambrosio in the left eye as well is highlighting. Again, I would not do laser vision correction in this eye, and instead would revert to phakic IOL. Epithelial thickness mapping is a great diagnostic tool. I use it for every single patient, especially patients where I'm thinking, okay, is this patient at risk for ectasia in the future? And the reason we use it is to make sure, is there any thinning? So there are many rules of epithelium, and Dan Reinstein has a great book about this and has lectured many times about the 4 rules of epithelium. When you have a patient who has steepness of the cornea, you have to make sure, is it from the epithelium, or is it a harbinger for ectasia? Could this be a keratoconus suspect? So if you had, let's say, a steepness, but then you had thickening of the epithelium where the steepness was, then you can say, okay, maybe the epithelium is causing the steepness there, and they probably could get laser vision correction. But if you have areas of thinning like this, and it's just a very irregular epithelium where the steepening is, then it's just not a good idea to proceed forward with laser vision correction, because the risk of ectasia is even higher in this situation. So for this patient, what did we do? We recommended EVO ICL. So the patient underwent a -3 in the right eye and a -5.5 with astigmatism in the left eye. And look, the patient actually gained lines of vision in one eye, and it was super ecstatic. So they saw better than what they did before the surgery with glasses. Now moving on to a second case, a 39-year-old male has worn glasses only for over 20 years. Global sales rep, enjoys traveling and enjoys a lot of food. And the reason I mention food is it's relevant, but look at his refraction. So -3 and -250 here. So you're looking at the -250 and you're like, wait, can I even do ICL here? But the problem is when you talk to this patient, in the US, we eat a lot of burgers, and overweight is just a much bigger issue, probably in other areas of the world. But we already knew this patient was going to be an issue, because when the team was calling him, they said, we need to get some registration forms before you come. He's like, I'm sorry, I got to get off the phone. I got to go and make dessert. So allegedly his weight was over 350 pounds. And the beds for laser vision correction actually have a weight limit. So if a patient is above 350 or 400 pounds, then we actually can't do laser vision correction. That's probably not a problem in Yemen, but that is an issue sometimes for patients here. So they can't even get laser vision correction. His cornea looks great. I mean, cornea thickness, Bellin looks beautiful, and everything looks great. But unfortunately, I had to tell this patient, like, I'm sorry, man, like, you have to go and lose weight. He went, tried to lose weight, took a course, did everything, could not lose weight, then had to come back and see me. I was like, look, doc, I mean, I give up. I'm depressed. I really need a solution to get out of glasses. So you look at his true ACD, and he was -250. So what did I do? Well, I put an ICL in the patient's eye, even though he was -250. And you might be, and he had a fantastic outcome, by the way. You might be wondering, like, wait, I thought you said the spherical equivalent range was a -3. So it starts at a -3. So how did you put it in a -250? Well, remember, in the US, it's -3 to -16 and up to 4 diopters of astigmatism. Outside of the US, people are more lucky. You can even go down to as low as a -0.5, which is amazing. But I don't have that option in the US. Well, it has to do with ICL power calculation. And this is different. So there are lots of classical formulas historically to how we calculate the power of the ICL. Well, the good news is Star Surgical has an OCOS, which is now called Stella, the newest version, that actually does all the calculations for you. But fundamentally, it's different. So when we vertex an eye, so when we're taking a patient from glasses to contact lenses, yes, for myopia, we go to less diopters of myopia. So here's an example where a calculation. So if you have a -10 diopter glasses, you're vertexing to about a -8 or -9 contact lens, because it's on the corneal surface. And you have the refractive index of air, and you don't have to worry about anything else from the lens maker equations in optics. And we all love optics, right? It's our favorite topic. No one loves optics. So moving from the glasses to contacts, vertexing is straightforward. It's something we're used to. But for ICL, it's the other way around. So a -10 pair of glasses is actually going to end up being a -11.5 at the effective lens position of an ICL. Why? Because you have the cornea. You have different refractive indices that you have to go to. You're closer to the nodal point, and optically, it's a different phenomenon. It's the other way around. So so when you see a patient and you're looking at them and, oh, they're a -2 or a -250, that doesn't mean that they're not an ICL candidate. Even going down to as low as a -250 or a -2.25, plug it into the calculator and see what it gets, because they could very well be a candidate. Even if you end up leaving them with a little bit of hyperopia with their residual accommodation, it should be fine. So for that patient, even though he was a very low myope, still did fantastic with an EVO ICL. Now, final case is a 28-year-old female. She wears glasses and contacts. She's a school teacher, and she's a big fan of the Jonas Brothers. In the US, that's relevant because the company actually advertised Joe Jonas, the singer, significantly, and she has high myopia, as you can see here. And she comes in, she doesn't even know what EVO ICL is. She just says, I want the Joe Jonas lens. So now with the marketing and how much of a hype there is with EVO ICL, we get patients that come in and say, hey, You usually will get patients who are like, hey, I want LASIK, because everyone knows what LASIK is. But now we're getting more and more of a brand for EVO ICL, where patients come in saying like, hey, I don't care what you think, I want this lens. So that was the first thing she said to me. However, her case was not as straightforward, which you'll see. She had thin cornea, so I agree. Laser vision correction is not the best option for this patient. But look at her true ACD. So her true ACD is less than 3. In the US, it's labeled as 3 millimeters indication-wise for EVO ICL for true ACD. Outside of the US, it's marked for 2.8, but still a lower ACD. And you look at her measurements, because now we have to start talking about probably one of the most controversial topics is ICL sizing. You look at the anterior chamber, it's a little bit on the narrow side, not the most narrow, honestly, but narrower than 3 millimeters. And you look at the white to white, so the horizontal distance, the corneal diameter is about 12 millimeters using the pentacam. We use UBM. So inside the eye, you'll see the sulcus is 11 millimeters, which is actually smaller. So her eye actually internally is a little bit smaller than what it appears externally. And her ciliary body inner diameter is also 10. So I'm looking at this case and I'm like, okay, well, this is going to be a fun sizing case. It's not as straightforward. But one of the questions that I usually get is, well, how low of an anterior chamber depth do you go? You know, in the US, the FDA says 3 millimeters is the safety mark. Can you go lower than that? And I don't want to go lower than that. Well, fundamentally, we have to ask ourselves, why? Why is anterior chamber depth 3 matters? What are we worried about? Are we worried about angle closure? Okay, well, let's talk about the angles. Let's talk about angles, not necessarily, okay, anterior chamber depth. Well, and what else? Well, you know, what about endothelial cell loss, right? If it's smaller, is the lens impacting the way aqueous flows, and is it going to cause endothelial cell loss? And you already know my feelings about endothelial cells, but there was another study that actually looked at this. So Camilla and colleagues looked at anterior chamber depth and the relationship between endothelial cell loss, and they looked at it over a year compared to various anterior chamber depths. So you can even see here an anterior chamber depth, the true ACD of 2.3. And you can see here, there is no correlation. So endothelial cell loss and anterior chamber depth, there is no correlation. It does not matter, quite frankly. So why am I worried about anterior chamber depth? More so, I'm worried about anterior chamber depth from a sizing, not endothelial cell loss. So the 3 millimeter mark, I do not take as a black and white mark, and I challenge that. Well, what I'm worried about more is ICL sizing, and it's a topic that's very near and dear to my heart, because it just confused me a lot in training. So a couple of years ago, I started looking at this and studying it. And what we know from the literature is external anatomy, so white to white, does not really correlate with internal anatomy. And I just showed you a case where there's no difference. Just because you have a white to white does not mean it's going to have a correlated sulcus to sulcus or ciliary body. The reason that's important is we know the ICL sits on the ciliary body inner diameter 90% of the time, and then about in the sulcus 10% of the time using ultrasound studies. Well, I presented this at ASCRS a couple of years ago, and I measured in over 200 eyes. I measured what's the sulcus to sulcus, what's the white to white, what's the ciliary body inner diameter, and you can see here there's variability. You can have patients that have difference between up to 1.5 millimeters between sulcus to sulcus, white to white, ciliary body inner diameter, sulcus to sulcus, and then white to white ciliary body. So as you can see here, eyes come in many different shapes and sizes, and that's one of the reasons why we have an issue sometimes with sizing. So how do surgeons select the size? Well, the way we measure is variable. As you can see here, some people use calipers, white to white 36%. Some people use white to white using biometry or tomography and various different devices. Some people use OCT, some people use UBM. So there are many different ways. And one advice I always have to every surgeon is do not alternate. So don't say like, okay, on Monday, I want to use calipers. On Tuesday, I want to use OCT. On Wednesday, I want to use UBM. Just have one way of doing things and stick to it and design your own nomogram, because then you're going to drive yourself crazy. And then how do you consider? Well, the industry, so Star Surgical has a nomogram that they recommend. Just keep in mind, this nomogram is based on the orb scan. And this is how you look at it. Anterior chamber depth, what's the size, and white to white. And this will get you to where you need to be most of the time. Remember, EVO ICL is more forgiving compared to the others because of the fenestrations, but you want to get towards an accurate way. You'll be in situations where it won't be exactly perfect. And that's where the mindset comes in. So when we're sizing EVO ICL, a lot of times, a lot of surgeons, they text me or they call me, they're like, Taj, like, oh my gosh, I have this case, I'm very stressed. I really want to make sure my vault is exactly at 500. Because we have this bullseye method. We're shooting a bullseye and we want to be right in the center every single time. Well, why? Because we're used to that. We're used to being within half a diopter spherical equivalent. If I'm choosing a lens, I want to make sure I'm within a half a diopter spherical equivalent. Well, ICL sizing is not like that. That's not the mindset that we should have. We have a parameter. So you can be between, 200-ish to 1,000. But even if you're beyond that, think of it more like a biathlon. So instead of shooting the bullseye and getting in the center every time, in a biathlon, you just have to get within that range. And if you're close enough, you're good because, quite frankly, the efficiency in getting to the next competition is more important. And that's the best mindset to have when you're considering ICL sizing, because it's not a perfect science. I mean, we'll get there eventually, and we're working on it to where it can be much more reproducible, but you're going to drive yourself crazy trying to nail 500 microns. It has to be 500 microns because, quite frankly, it's not going to happen. So going back to our case, when you run the sizing, and this is an exercise sometimes that happens, and keep in mind this patient has a narrower eye, so already we have to consider that, okay, I got to make sure that I'm more accurate. So FDA manufacturer, the size recommendation was 13.2. I use an optimized manufacturer nomogram that we developed here in the US that recommended a 12.6. Parker's nomogram. So Greg Parker's was my mentor. He's the one who trained me, and he's the one we did the FDA trials. He created his nomogram back in 2011. So we use ultrasound biomicroscopy. His recommended a 12.6. Well, Dan Reinstein has his nomogram with the ARC scan. So it's a high frequency digital ultrasound, and it recommended a 12.1. So I'm sitting there looking like, okay, what should I do? Should I do 13.2? Should I do 12.6? Should I do 12.1? What should I do? And that's the issue we have sometimes with nomograms and ICL sizing. It's not a perfect science. So when you look at nomograms, well, what are the nomograms that are out there? Well, you have the FDA manufacturer's nomogram, which we use. We have ultrasound biomicroscopy. So Dr. T started that in 2007 in the US. My mentor developed another one where he started to look at lens rise as well. You have Kojima and Lee and many other colleagues who use ultrasound biomicroscopy, which is great because ultrasound biomicroscopy gives you a view inside the eye, but it's not necessarily the be-all end-all. I'm not saying that for ICL sizing you have to do ultrasound biomicroscopy. It's helpful in my opinion because I'm biased, but it's not the only way to do things. Anterior segment OCT, this is much more common in Asian countries. So Japan, South Korea, and also in Belgium, they used various different devices and came up with many different nomograms using anterior segment OCT. And you also have multimodal diagnostics. Zaldivar, he's a good friend of mine. And for those who don't know, so the Roger and Roberto, his father, they were the ones who invented the actual holes inside the ICL. So thanks to them, we actually have the EVO ICL. So he has a really nice nomogram that just came out, and I actually was working with him because I was developing a nomogram and he was developing a nomogram, and then we talked to the company at the same time. But he ended up having the collaboration with the company, and his nomogram is called ICL Guru, and he's using many different modalities. And the hope is for our team and Zaldivar's team to work together. Because he's developed the ultrasound biomicroscopy nomogram, we're going to work on an OCT nomogram together in the future. And basically what it uses is machine learning. And I want to talk about that a little bit because external anatomy, as we talked about, doesn't correlate with internal anatomy. And the issue with a lot of ICL sizing is we're relying on regression data. So rudimentary statistical analysis. We're relying on models that are only on numerical factors and predetermined variables. So you're looking at, okay, what's the sulcus, the sulcus, the sulcus, the sulcus? What's the white to white? What's the ciliary body inner diameter? And you're only looking at specific variables. Well, that frustrated me when I was looking at this, and I studied it and presented it at ASCRS, where we looked at over 200 eyes, and I studied and looked at, okay, with our nomogram with Reinstein, and Reinstein was one of the best nomograms that we used, we still had 8% of our subjects that were 300 microns higher or lower than we expected. And to me, I was like, well, I mean, we're using white to white, we're using ultrasound, we're using everything, but there's still this big difference for some patients. And what was even more alarming to me was if you only use the white-to-white nomogram for these patients would have been oversized for almost half of our patients. So for almost 48% of our patients, I would have had to put a one size larger ICL. And to me, I was like, okay, there's got to be a better way. And this was about 2 years ago now. So I talked to my mentor. I said, man, like, we can develop something better. Why can't we work on artificial intelligence? Because I had read in the literature, there were colleagues in Asia and in Belgium that were starting to use what we call machine learning. And what machine learning is developing higher functions of statistical analysis. So you're looking at data and you're making it in a much more abrupt way. So you're running numbers much faster. But there wasn't a nomogram out there that looked at deep learning because AI was much more popular at that time. It just came out, ChatGPT, large language models, lots of things came out. And so I went to my mentor. I said, hey, we can be the first to develop this deep learning nomogram. And so the idea that I had was, okay, let's stop looking at variable to variable. And so we created this company called Vault. And this is the team. So this is my mentor, Greg Parkhurst in San Antonio, and two other colleagues of mine. We got together and I told them, like, look, let's come up with a better way to do things. And our idea was, instead of looking at predetermined variables, let's look at pixel to pixel. Let's look at the whole shape of the eye. So I don't necessarily want to look at where does the scleral spur from the scleral spur, or what does the angle look at, or what is the sulcus to sulcus, and just do it into machine learning. My idea was, let's look at deep learning. And let's look at the shape of the overall eye, because every eye is different. You have eyes that are smaller inside but bigger outside, and the other way around, that are smaller on the outside externally but much larger on the inside. And so to me, is a picture says a thousand words. What if we could develop a nomogram where we just show it a picture and it brings back to us an actual result? And we published this in the Journal of Cataract and Refractive Surgery. So we were the first nomogram to ever come up with this idea. And at the same time, Roger Zaldivar was also coming up with the deep learning in his ICL Guru. And this is an example of a case. So this same case that I talked about, you go to Vault, you look up the UBM data, and you place the images and you upload. So we devised this. And the idea was, look at the pictures, have deep learning, have this artificial intelligence nomogram, analyze that data, and within 5 to 7 seconds, you have a predicted vault. So what would your vault be with a 12.1, a 12.6, and a 13.2? The issue we're having is we need a lot of data to make this really robust and release it. So you need tens and tens of thousands. So we started using it with ultrasound biomicroscopy, and for this patient, I got a predicted vault. And you look at all the data. So FDA manufacturer 13.2, optimized 12.6, Parkhurst 12.6, Reinstein was 12.1, and then Vault was around 12.1 that was going to give us close. So we ended up choosing 12.1. And the patient had an amazing result. So the patient with a 12.1, again, if we only used the manufacturer, we would have put a 13.2, so 2 sizes larger, and had a great result. And actually, Vault outperformed Reinstein. So we were super happy about that, and that this nomogram actually can work. And deep learning as an idea has huge potential over the next couple of years. And so that's ICL sizing, which, again, the mindset. It's not about perfection. There are cases where you have to choose between two sizes, and erring on the lower side sometimes can help, but there's a little bit of finesse to there. But again, it's not a perfect science. The last portion of the lecture, I wanted to focus on the patient conversation. I know we only have a little bit of time left here, and it has to do with, sometimes we get patients and we don't know how to present the value of it, and they come to see us and they're like, okay, I only want LASIK, or I'm not sure about getting out of glasses or contacts. And really, the way to talk to patients is to talk about the advantages. Focus on the science and focus on the advantages. Why is EVO ICL the better option? Well, we looked at this, we studied this, we published, and we found that 50% of our patients who were either amblyopic or keratoconic actually gained lines. So patients are gaining. So you have sharp vision, excellent night vision. We simulated this with night goggles. Dryness as well. Compared to LASIK and PRK, you won't have to deal with as much dryness. Quick recovery. We're not really touching the eye. It's reversible, and who doesn't like a little bit of sunglasses in their eyes? And how do I remember that? This is something I do when I'm teaching other surgeons, because they're like, okay, when I'm talking to a patient, I don't know how to remember all the different benefits. Well, one of my friends came up with this really nice mnemonic, And it starts with an E, so excellent vision, stressing to the patient the visual outcome that they're going to get in the studies that show. U, UV protection, and we have to get a little bit creative here, but UV protection, this is the only technology that actually gives you UV protection in your eye compared to other. O is no or minimal post-op dryness. And you can see how we're going here, EVO ICL. So it is reversible. We can take it out. And then C is cornea sparing, which is very appealing, especially for some of our optometrists and patients. It's really nice to be able to maintain the natural shape of your cornea, and it saves you options for when you want to have cataract surgery in the future, and we're not scratching our heads. Okay, this patient had PRK, what calculations? Oh, this patient can't get a trifocal lens, etc. And then longevity, same kind of aspect. So I'm giving you an option for you in your future when we're talking to our patients. So the question that comes up from patients like, okay, why should I get EVO ICL? Why should I get added glasses and contacts? What's the value there? And talking to patients can be difficult, but remember the value equation. This is from a business principle here. When you're talking to your patient, there are 4 fundamentals that you have to look at. One is the dream outcome. When you're talking to a patient, you want to talk to them about the dream. You don't just tell them like, okay, I'm going to get you out of glasses. What does that mean specifically? It means Hawaii. Think of Hawaii. It means rainbows and sunshine. When you're describing a vacation to someone, you're telling them like, okay, we're going to get you to be able to enjoy seeing your son's, precious eyes as his activity. We're going to be able to get you to be able to enjoy you playing soccer or swimming without glasses. So painting that dream outcome to them instead of telling them like, oh, you want to go to Hawaii? Well, if you want to go to Hawaii, you have to get on a plane, and then you have to endure 10 hours of traffic, and then you're gonna have your kids, and it's gonna be a hassle, and you might end up with endophthalmitis and retinal detachment, and scaring them before they even want to have EVO ICL with you. So think about the dream outcome. And so Star Surgical did an amazing job where they said, look at Joe Jonas, new vision. I am able to upgrade my performance, upgrade your vision. So give your patients, empower them with the dream outcome. Again, this is the top part of the equation. So the dream outcome is important when you're talking to your patients. Another important factor on the numerator here, you multiply it by the perceived likelihood of achievement. And what that means is your personal credibility. What is your work? What evidence do you have to your patient that you're legitimate and that patients have gotten great outcomes? And that has to be with your branding. Well, lots of people have had surgery. Joe Jonas had surgery with this lens. We had amazing basketball players. Oh, we have lots of people who've had this and nothing happened to them. Actually, one of my doctors had EVO ICL and they're doing great. Your reviews on your website are extremely important. Patients are much more affluent. They're looking us up. They're seeing our reviews. And how much confidence do you have when you're talking to your patient? Patients, when they first see me, they're like, oh my gosh, like, how old are you? Are you like still in high school? You have to show them that, hey, look, I'm board certified. I've done thousands of these. I'm actually a trainer. You'll be in good hands. So the perceived likelihood of achievement is tremendous when you're presenting a value to your patients and talking to them about how you believe that this is the best thing for them. So these are the positives. These are things to focus and do more of. Well, what are the negatives? What's on the denominator here? Well, one of them is time delay. So when a patient comes to see us, and we talk with them, we say, we have to order your lens, and your lens isn't going to be here until 2 months. Forget it. They're going to go see someone else. So getting it to them as soon as possible, getting the measurements, reducing the number of times that a patient sees you makes a big impact. And the company that does this really well is Amazon. I mean, they are way ahead of the curve that people don't even, like, if I want to order a coat or a jacket or something, I don't even want to go to a supermarket anymore or order food or anything. You have it on your phone. And Amazon has paid so much attention to this that you don't even have to click a couple of times. You can just swipe once and you'll get your coat or whatever you want the next day or even within the same day. So time delay, because, patients and your potential prospects are seeing customer service and what is the value that you're offering. So reducing the time delay as much as possible is crucial for patients, especially if you want to build a brand and grow long term. And then the final thing is effort and sacrifice. And this is one of the reasons why EVO ICL was huge for ICL. So those holes in the ICL prevented patients from having to come and getting the PIs and going through all the effort and sacrifice. Now they can just come in, I sign you, I'll order your lens, and you'll have surgery and you're done. So that reduced the effort and sacrifice tremendously. And a great example is what happened with Blockbuster, which was a company that sold movies, CDs, and DVDs back in the day. And then Netflix. What did Netflix, what did this streaming, online streaming do? And it's the effort and sacrifice. I don't have to get in my car and drive and go to Blockbuster and talk to someone and get the DVD and go home and open the CD and take it out and then put it inside. Now I can just go on Netflix, turn the remote, sit on my couch and watch immediately, instantly. So I have no more effort and sacrifice. And that's why Netflix ran Blockbuster out of business. Blockbuster ceases to exist because the consumers have no more effort and sacrifice. So we should have the same mindset when we're seeing these patients. Is okay, why am I going to bring you back 4 times to get a bunch of different measurements? Why am I going to I'm going to call the company and I want the lens to come in within a week. So if we can make it as easy as possible for our patients, we've increased the value tremendously for them long term. So again, this is, to summarize, this is again, this material is from Alex Hormozy. He's a really good entrepreneur and focuses on, and this is what I use to train other practices and other clinics on how you can get more ICL patients inside your door, because we know EVO ICL patients are extremely happy.
So right after the surgery and I opened my eyes, I realized that, hey, I can see. And I was trying to hold back the tears, but it was really such a great and overwhelming experience to know, like, immediately after surgery, you were able to see. Today on my 1-day post-op exam, I was able to see like 20/20 in this eye and 20/15 on this eye. So it's pretty incredible when I was just having surgery yesterday and having that type of vision today.
So this is a patient who was an eye doctor. So she's an eye doctor and she had EVO ICL in her with us. And so what you see in this video is you see a testimonial, you see a perceived likelihood of achievement, you see something that was easy, no time delay, very less effort and sacrifice, and you see the dream outcome. You can see how she's smiling, you can see how her vision was immediately the next day. And so this is the kind of examples that you want on your website. You want to show other patients and encourage them, and they look at it and they say, wow, even an eye doctor gets the EVO ICL in their eyes. And so extremely happy. I mean, patients are some of them happiest. So my favorite kind of patient is the EVO ICL patient, because some of these patients are very high diopters of myopia, and it's very life-changing for them. This is my friend, actually, Matt Hirabayashi. So I did my training with Parkhurst, and he's the current fellow there now after me. And he had EVO ICL in his eyes, and so I got to be a part of that experience with him. And he chose that for his own eyes, and he's an eye surgeon. And this is one of my favorite patients. So this was a patient that I did EVO ICL on. She was very nervous, and she works as a news reporter. She's on the news, and a whole year, so 1 year after her surgery, she sends me this letter. She mails it, and one of my staff says, "Hey, Dr. Nasser, you have a mail from one of your patients." And she writes, she ran out of space, so she wrote 3 pages of, "You did my EVO ICL surgery." And I remember, and every single day I've been thinking about it. Can you imagine like how satisfying it is for us to be able to take care of patients, and what a privilege it is? So every day I've been thinking about this. And she was smart. I mean, she was very nervous, and she went on Google and she searched everything, and I had to talk with her for hours and hours before she even did the surgery, because she was like, okay, I know the common ACD was 2.8 outside of the US, and I know I'm a borderline case, and we had to go through a lot before she even went through the surgery. But it mattered so much to her that she sent me pictures of her on the news. She sent me pictures of, I was so stressed about where am I going to wear my glasses or contacts when I'm my engagement or my wedding. And she sent me pictures of her engagement, and she's so happy. So that's the opportunity that we have to really change the lives of our patients, to a point where a year later, every single day, she's waking up and she's like, this is amazing. So it's such a privilege, and it's something that I enjoy doing every single day. And I hope, the message that I can with this lecture is to really encourage other surgeons in our beloved Yemen to also adopt this technology, because we can make a big difference in patients' lives. So I haven't forgot. We're going to wrap with our patient. Remember how I started this lecture with this 16-year-old that came to me about 5 years ago? And I still think about this case because I went to my attending. He was a pediatric ophthalmologist, and our chair at the time was a retina surgeon, which, I have respect to retina surgeons and pediatric ophthalmologists, but sometimes the mindset isn't there compared to refractive. And they both thought there was no option for this patient. They both talked to me and said, no, this patient should never have surgery. There's no option. And I didn't know much. I was still a resident, so I was still in training. I didn't know anything about ICLs at the time. So I had to go in and talk to the patient and talk to the parents, which was difficult. And I had to tell them that I'm sorry, like there is no option. I'm sorry, you should never have eye surgery. And to me, that stuck with me, because after that, I went home and I started to read about ICLs. And that was the point where I was like, you know what? I need to learn more, and I want to pursue a fellowship in refractive surgery, because I never want to deprive a patient from an option. And that's a message that I want to send across, is if you see a patient and they could be, and you're not sure if they are a candidate, don't take all the hope from them and crush their dreams and their parents' dreams, because sometimes these patients really need help. And for me at that time, 5 years ago, I didn't know any better, and dogma prevailed. So dogma caused me to say, no, you have no option. I'm sorry. Like, you should never get surgery. And when in doubt, just remember, we can talk, we can say lots of words that may inspire, but only action creates change. And I hope we can take an action going forward to consider the many benefits of refractive surgery, and also EVO ICL as an option for our patients. So thank you so much for your attention. This is the way to contact me. I included my cell phone and my email. I'm always open to messages on my WhatsApp. You can text me, you can email me, social media. I'll be available to help out, and I hope I can connect more with you all. Really excited. Thank you so much for the opportunity. I want to thank Noor Alyemen, Dr. Abdurrahman, and Dr. Amr, and all the amazing doctors there. I look forward to working more with you all. So thank you.
Thank you, Dr. Tag, for fascinating lecture. Really, we enjoyed it. I'll put the first questions as a VR surgeon, because I face a lot of cases with ICL, and then RD occurred. Some issues may confuse me, like there is some cases after silicone oil injection, cataract develop. So I have to calculate the IOL properly. So if you have any suggestion about the formula, I'll be thankful. Also, I have some issue about the removal of the ICL, IOL while cataract removal. If you have any tricks, you can guide me about it, please. This is my questions, and we will let the others to ask you their questions.
So first question is about the silicone oil. We have the weight on our biometers. I don't know what kind of biometer that is used, but there's a silicone oil option, because it does impact the way that the refractive index is within the silicone oil, and you're going to have to adjust the IOL power. We have ways to do it automatically here, and there's an online calculator.
We have IOL master, and we can adjust the machine for the silicone oil parameters. But sometimes there is a shift in the refraction after the removal of the silicone and the cataract removal. It's not the big issue because we have already written attachment.
Mm-hmm.
Yes, but I want, if you have any trick about this, I'll be, it will guide me in the next cases.
Yes, I usually err on the side of altering the myopic correction as much as I can for these patients in anticipation of silicone oil removal. But again, for these retina patients, the expectations are way lower. So when I'm talking to a patient, I tell them, look, you have silicone oil in your eye. Typically, I talk to the retina surgeon and I can see, can we take the silicone oil out first? But sometimes you can't. You have to take the cataract out first. So if we can take the silicone oil out first, that's preferable. If you can't, then I'm going to adjust my power calculation. And I usually use an online calculator, and I can talk to you about it. And there's some studies that we can look at how much of diopters of myopia to alter. But then most importantly is I talk to the patient. I say, look, ma'am, sir, you're going to end up with a very different refraction afterwards, a couple of diopters up or down, as an expectation. Because I don't want the patient afterwards to say, oh my gosh, I got my silicone oil out. And a lot of times these patients, like you said, their macula is not well, they have diabetes, they have TRDs. Refractively, they're not as of high expectations. But I will coordinate with the retina specialist and alter the diopter correction with, it depends. I think it's like 1 or 2 diopters, but I'd have to double check on the actual calculation, which we can
Yes,
go
yes,
over.
yes.
As far as the second question was about ICL removal,
Yeah.
and I know we have a couple other questions in the chat. ICL removal, I have a couple of videos on the refractive curriculum on that website that I sent you all. It's very easy with ICL. I've even done laser. So we use femtosecond laser, and I've even done femtosecond laser through an ICL. The good news is the ICL is very transparent, and the femto will actually go through it, and I'm never worried about taking it out. As far as taking it out, my preferred method, there's a couple of different methods. My preferred method is to rotate it diagonally through a 3 mm incision. You can even do 2.75 if that's how you do your cataracts. And then I take a long forceps. So we use a Dietz ICL forceps. I take a long forceps and make sure you grasp from the optic. So make sure you have a portion of the optic, not just the foot plates. Sometimes if you pull the foot plate and you pull it out and you don't use a 2-hand technique, it'll rip the foot plate, and then you're going with multiple different pieces. So I just take a long sweep, take the central optic, and you just pull out, and you're very steady and gentle. There are videos in that curriculum that show you how to remove an ICL, and I'm happy to send it later if you all need. And you gently
Oh,
remove it, and the whole ICL folds out and comes out easily because it's very biocompatible. For acrylic, the IPCL, it's different. The IPCL, if you're ever in that case, it's acrylic, you probably will have to cut it. I haven't removed an IPCL personally, but from some of my colleagues, they prefer to cut the acrylic and not deal with, because it's not as flexible. I hope that answers those
okay.
questions.
Okay. Thank you. I'll let the others for the
Yeah,
questions.
thank you. I see
Uh,
Khalid Al-Amir.
you can answer the chat questions now.
Okay, perfect. So Khalid Hizam Al-Amiri, he says, high myopic anisometropic child, what is the best earliest age to do ICL for childs, and can it be done for hypermetropic? So pediatric ICL is a very interesting topic. We don't do it in the US. The problem with doing it in childs is the sulcus space enlarges with time. So if you're going to do, I have a colleague, so in Argentina, the Zaldivar Institute, they're starting to do studies where they do myopia control with ICL, especially in the high myope child. So they're starting to put ICLs. The only problem with that is you have to monitor them closely, and you're going to have to exchange the ICL because the eye is going to grow. For me, the youngest age I do is 18. And I talk to the patient at 18, and I try to give them a higher vault at 18. Vault will change over the course of 10, 20 years, about 100 microns with the EVO ICL compared to previous iterations. So I'm not really that worried about vault. But for me, it's 18 years old is the youngest. As far as hypermetropic, there are hyperopic ICLs. We don't have access to it in the US. You have access to it outside of the US. It's the Vizian model. So the company just doesn't have that much of a demand to create an EVO model. So you have to put peripheral iridotomies in these patients. So there are hypermetropic. I think it's from 0 to +10 in the Vizian ICL model. And for hyperopic ICLs, it's actually a little bit better and less cataract formation, because it's thought that the hyperopic ICLs, the convex nature does not lead to as much of stasis as the myopic ICL. So my colleagues who use hyperopic ICLs loves them. The only problem is the angles are smaller in hyperopic patients, so the anterior chamber depth and angle criteria are a little bit more strict. So I would just practice extra caution with hypermetropia in those ICLs. I hope that answers your question. Majid Tam, question is, what are the key criteria for determining if a patient is a good candidate for EVO ICL? So for me, key criteria is space. So I look at their angles. So I like to have angles above 20 to 30 degrees. And then the anterior chamber depth, I go as low anterior chamber depth as 2.6. So if it's less than 2.6, I start to worry about too much angle crowding. So if their anterior chamber depth is good, their angle is good, and their refraction is there, then me, candidacy-wise, I'll offer ICL. Anyone who's above -6 diopters, I primarily offer ICL over laser vision correction. And my practice is, the way I explain it to the patient is, it gives them, I think, a better quality of night vision, because we're inducing less higher order aberrations for these patients. So instead of me inducing a lot of higher order aberrations on the cornea, I'm implanting an ICL. So anyone who's over -6 diopters, I primarily recommend ICL. I don't recommend laser vision correction if they're a candidate. But those are the main criteria. Is also, just like with any refractive patient, you got to make sure they're healthy. So they don't have retinal detachments, they don't have diabetic macular edema, glaucoma. Anyone who's not a healthy eye, I do not recommend EVO ICL. Majid Tam, how does EVO ICL perform in patients with high astigmatism or irregular corneas? Great question. Expectation-wise, I always, any patient who has, in the US, I only have up to 4 diopters. Outside of the US, I think you guys can get it up to 6. For me, anyone who's over about a 3.25 diopter of astigmatism, I always tell them you're going to need a touch-up, because 4 diopters of astigmatism at the spectacle plane is only about 3.25 at the ICL plane. So I'm already telling them, like, look, I can't correct all of your astigmatism. It performs really well. With astigmatism cases, the toric lens can rotate a little bit. We have a video on the curriculum about toric rotation and how to avoid that, so you can see that. Irregular corneas, keratoconic patients, make sure they're stable. I've done it in many keratoconic patients. It really depends on how irregular the cornea is, and what the best corrected vision is how I practice clinically. Sometimes if a patient is best corrected 2100 or worse, and they're in scleral lenses, and they don't want to touch their eyes, and they know they're going to continue to progress, then I don't do that. But if a patient is decent, they're seeing, best corrected with glasses, a 20/40 or so, their irregularity is not too much, so their IS ratio is not, significantly aberrated, then I usually cross-link them. So do cross-linking and then do ICL 6 months or a year later, telling the patient that I'm going to buffer your refraction. Sometimes their astigmatism is not that high, so I can get all of their treatment with an ICL, but I'm also talking to whoever's fitting their lenses. Because sometimes if you put a toric ICL in a patient who's getting fitted with sclerals, the doctor who's putting sclerals is going to hate you, because now you've unmasked their toric toricity inside the lens. So I always talk to whoever's referring, and I tell the patient, look, I'm going to do this ICL, you're keratoconic, you're going to have some irregularities, but you might still need some sort of scleral afterward if you want perfect vision. Now, patients have done well. I think their brain are just used to the irregularity from the keratoconus, but I have been pleasantly surprised. These patients notice a difference as long as you select them appropriately for keratoconic and irregular corneas. What is the typical visual acuity outcome for patients after ICL implantation? So visual outcome, as I've shown you, is the same as LASIK or PRK from a predictability standpoint. Within a half a diopter spherical equivalent, we're getting over 90% of our patients who get ICL. And then stability-wise has also been shown. So when you look at the standard refractive nomogram for ICL, it is not different compared to LASIK or PRK. The only thing that I've noticed personally in our studies is that patients with ICL tend to gain a couple of lines. And that's probably something that I'll study in the future, is especially for higher diopters of myopia, you get more of a magnification with an ICL compared to LASIK, because it's closer to the nodal point. So I wonder if we get more gains of line of vision with ICL compared to laser vision correction. But we don't have strong evidence for that. Dr. Fadi Mukrid, hi, Dr. Fadi, is the pupil diameter before surgery, does that matter? Pupil diameter before any refractive surgery does matter. And the way it matters is expectations. So when I'm talking to patients, if their pupil is pretty large, and you can notice they're pretty large when they're physiologic, then I'll always talk to them about halos. With ICL, the halos they get is a little bit different compared to laser vision correction. They usually see this circle, and sometimes it's like this big circle around that gets better with time because of neuroadaptation. But as far as pupil diameter and me being able to put an ICL in, no contraindication. I've done ICL in patients with a 7mm pupil, physiologic, like when you see them, you think they're dilated all the time, and they do well. The reason is the ICL is actually tucked within the ciliary body sulcus apparatus, and it does really well. And there's been studies that shown that people in the military that got shrapnel inside their eye, the ICL was in stable position. So it's just a matter of outcome and the halos and glare. So for every patient that if I'm doing LASIK, PRK, or ICL, I always talk to them, expect halos and glare, because expectations are resentments in the making. So if you don't say that beforehand, the patient's going to say, oh my gosh, you made my life miserable. So I tell everyone, you're going to get halos and glare. If their pupil is larger, then they will get that, especially if their diopters of myopia is larger. So patients who have higher diopters of myopia are going to end up getting a higher diopter of lens. And the higher diopter you go, the smaller the optical zone of the correction, even in an ICL is. But the good news is the EVO ICL has a little bit of a larger optical zone compared to laser vision correction. In laser vision correction, we use an optical zone about 6.5. For EVO ICL, it can go up to 6.9 to 7. So I hope that helps. How to avoid post-op halos? Again, it's there's no really good way. I mean, some people have tried orienting the ICL horizontally compared to vertically. I haven't noticed that big of a difference as far as halos. If patients are going to get halos, they're going to get halos. Post-operatively, the way I troubleshoot sometimes is I'll give them a topical meiotic agent. I try to avoid the diluted pilocarpine, which is called Vuity, because I don't want them to end up with any possible retinal detachment or anything. But a little bit of bromonidine. So I give them a little bit of topical bromonidine to help the pupil a little bit. And if I need to, then we have other topical meiotic agents that we can use that helps them. But I mean, there really hasn't been as good of a solution for the halos situation. Otherwise, sometimes patients will use a pair of, especially when they're driving at night, they'll use tinted, either rose or yellow tinted glasses that are clear. And I've had patients that are like, oh my gosh, it helps my halos a lot at night. But the good news is, I always tell my patients, just give yourself a year. So after a year, if you still don't like the halos, then we can talk. And I've only had one patient. So I've done hundreds and hundreds of these. And I've had one patient say, Doc, I hate my ACL. Take my ACL out of my eye. And I was like, are you sure? And I saw him a couple of times. He was a -7. So after a year and a half, he said the halo. And it was because of the halos. That's legitimately the only reason why. So I took the ICLs out of his eye. And then a month later, he comes crying. Like, oh my gosh, put the ICLs back in my eye. I refused. I was like, no, I'm not doing any more surgery on you. But it was because of the halos. And when I took the lenses out, he was miserable. He wanted them back. So now I almost never take an ICL out because of halos. And I just tell them, like, look, you're not going to like your life. And I would recommend, if you ever get a patient that's like that, just give them a pair of glasses, or simulate to them what it would look like what they had before, and have them walk around with it, because then they're going to come back and say, oh my gosh, like, I'd rather live with good vision and halos than to not have halos and then not have good vision that I had before. And then another question is, what is your attitude towards high myopia with decreased BCVA, amblyopia height? Okay, great question. It depends on how bad the amblyopia is. And it depends on the patient expectations. So I've done this in a patient with retinitis pigmentosa. So I had a patient with retinitis pigmentosa. His best corrected was 20/80. I don't do, like, I try to convince them not to do it as much as possible. And they were ecstatic. They actually gained 2 lines of vision. And the patient, however, here's the difference. The patient was informed. So I talked to the patient extensively, like, you'll have retinitis pigmentosa. You will go blind one day. Your vision is going to continue to tunnel. You're going to go blind. But the patient understood that. And the patient said, like, don't worry about it, doctor. I understand. I just want to enjoy these next couple of years with better vision and not have to worry about it. If I'm going to go blind one day, I might as well have a good vision without glasses and contacts. And I've done that before. But I try to avoid it unless I've had several documented visits with the patient. I've had them sign a special consent. And, it has to be someone who's very desperate. Patients who are 20/40 amblyopic or better, I'm not sure what it is in point, because I know you check vision differently, but 20/40 is a cutoff. If they're better, then I do that, no problem. Any patient who comes to me and they're 20/40 or better, I put an ICL without issues. because I think it does help them, and they're more likely to gain a couple of lines of vision. And 20/40 is the usual cutoff for us for driving, and so that's why I use 20/40. High anisotropia also, they do really well if they're a -10 in one eye and a -3 in another. No problem at all. That's a great candidate for ICL, and I would recommend that as well. Okay, I think we got through all the chat questions. Anyone else have any other questions?
شكرا دكتور تاج، حقيقة استمتعنا جدا، وإن شاء الله في محاضرات قادمة على نفس المنصة بإذن الله. ويعني احنا إن شاء الله يعني إذا في أي أسئلة أو أي حاجة we will keep in touch إن شاء الله بإذن الله.
على الرحب والسعة، تشرفنا.
ومستني مستني الفيديو تبع الريموفال. انا بعمل نفس الطريقه اللي قلت عليها وبخرجها بون بيس، لكن I think you will guide me better.
Let me,
ف
I think I can send it to you all in the chat. I have.
اوكي يستفيد جميع الزملاء منها، لانه عندنا حالات كثيره والحمد لله لما نتائجهم ممتازه. يعني كثير منهم انا اسيبهم بالاي سي ال، واذا في مايلد كاتاراكت يعني I left it. ما
So
بعملش كاتاراكت يعني.
this is the video that I made. It's on my LinkedIn account. Let me see if it shows up to you all. So I sent you a link.
Yeah.
And this is the ASCRS video that I made a couple of years ago. And it has a couple of things. It has one, how to do ICL. And then two, what if you have a constricted pupil? What if you have to operate superiorly? What if the ICL flips? And then at the very end of the video, Dr. Abdurrahman, there's how to remove an ICL. There's a video of how to remove an ICL.
Okay. Thank you very much.
Anytime. I think someone raised their hand. Someone else have a question?
إذا في أي question يا شباب قبل ما نخرج من المحاضرة. اوكي، شكرا دكتور تاج، ما نعطلك، انا عارف انه معك شغل، وان شاء الله في لقاء قادم. شكرا جزيلا.
فرصة سعيدة، واتمنى للكل الحظ السعيد. اذا عندكم اي اسئلة ولا استفسارات يعني تكلموني في اي وقت.
اوكي we will collect it ان شاء الله. اذا في اي حاجة حنرسلها لك باذن الله.
الله تحياتي، مع السلامة.
شكرا جزيلا. شكرا لجميع الزملاء والزميلات اللي حضروا. ان شاء الله الباقيين ممكن يشوفوها على المنصة باذن الله. شكرا جزيلا.
ان شاء الله. الله معكم. مع السلامة.
يلا، السلام عليكم.